This morning, we're going to go over the basic principles and some details of history and physical examination with an overview concept. The target is the general principles of history taking and physical examination for medical students. The first concept is that the student usually introduces himself to the patient by name and explains who he is. There will be a history, which will be the story for the patient. There will be an examination. And then there will be what's called a working diagnosis. In other words, there'll be some working hypothesis about what has gone wrong. And then following on to that, there will be a list of investigations and management. And that is the sort of prototype for any history. Just reminding yourself, when you do introduce yourself to the patient, make it clear to them that you are a medical student and you're here for training. And then ask their permission to carry out the history and the subsequent physical examination. Starting with symptoms and going back to the history then, it's very important that you document the date and the time that the history is recorded. At this point, you open the history taking by asking the patient why he's in hospital, what has brought him or her into hospital, or what they feel is the main problem. And this is called the presenting complaint. Usually there is more than one presenting complaint. And it often comprises of just one or two words, shortness of breath, chest pain, or loss of power in the limb or something like that. Usually we don't like more than 4 or 5 presenting complaints to deal with. And we list them in terms of their chronological order. In other words, when they occur, or if they occur in sequence or at the same time, you just list them. In summary then, you may have 1 or more presenting complaints listed. Now we go on to the most important part, which I think is the history of the presenting complaint. And that involves describing each presenting complaint in detail. The way I do it is I ask the patient to tell me the story of what has gone wrong. For example, if the patient is short of breath, tell me how does it affect them, and how bad is it, when did it start, is it getting better, getting worse, have they had it before? And usually this will be a story, and the student either chooses to write down most or all of what the patient says, or summarizes it, or what we call synopsizes it, or interpret it first, then summarize it. Whichever method you choose to use, the first method is rather long, but is usually very valuable. At this point, I'd like to emphasize what is called the nature or the character of each symptom. And that's important to write down. And I often write down the patient's own words. The details of that are very important. And I've already mentioned that each presenting complaint will have a character or a nature, a site or a location. It will have a severity, a time course, which means an onset, a duration, and how it is now, or a frequency if it's intermittent. It will have aggravating factors or relieving factors, that is, things that make it better or make it worse, and will have associated factors. In other words, occurring at the same time as the presenting complaint. For example, shortness of breath may be associated with chest pain. There will also be a past medical history, which would involve sometimes this complaint coming to the attention of a doctor or even being hospitalized with it, and there may be some medications concurrently, and it is important to document those. And now at this point, the students, modern students, or at least, I mean, we all did, but we can incorporate the what's called the system review of the relevant system into the history of presenting complaint at this stage. For example, if I am short of breath and I have a cough, well then I'm thinking of the respiratory system. And in addition to shortness of breath and cough, I will ask about chest pain or fever or night sweats, symptoms that might or may not be relevant to the particular system. Personally, I don't do systems review at this stage. I tend to incorporate it after the past history, family history, social history, etc. I know some students have a fashion for incorporating all the systems review into this. I personally don't do that. I think it takes away from the specificity and the importance of the presenting complaint. I'm emphasizing to incorporate medications that are relevant at this point. And it's also important to document who actually is the informant. Sometimes the patient is too ill to give you the history, and it will be another family member. Moving on now, past the presenting complaint and the history presenting complaint to the past medical history. What do we want to know from the past? Well, logically, you'd like to know if the patient had any medical illnesses that the patient is aware of, any hospitalizations, any operations. And in each case, you'll want to know when they happened. In other words, a time course. Usually a year is sufficient. It is important to document at this stage whether the medical illness is active or inactive. What do I mean by that? For example, I'm a diabetic, you're a diabetic for life. So that's an active problem. A road traffic accident would be inactive. And that's an example of both of those. Specifically, we go through a list of diseases that we often ask about in the past medical history, and if it's relevant, in particular hypertension, diabetes, and for example, rheumatic fever sometimes in our community, somebody presenting with heart failure, pregnancy, etc. These may all be relevant. Family history. Family history is important for two reasons. One, genetic, and two, environmental. So who do we ask about in family history? Well, a rule of thumb that I use are first-degree family relatives. That is, siblings, brothers or sisters, children, or parents. Sometimes we extend beyond that, where there's an obvious genetic disease. If it's relevant, then you have to document the family tree for each of those, if they're affected by this disease that is in question. And at the same time documenting the outcome of that disease. That may be important in terms of the disease that your patient is presenting with. Examples of hereditary diseases might be, for example, diabetes is strongly hereditary, particularly type 2. And now we have sickle cell disease in our community. And we also have some other hereditary diseases that are probably less common. Moving on then to social history. Well, if you think about it, the logical sort of questions you want to know is about the patient. Number one, probably what is your occupation? Are you currently employed? Number two, what are your social habits? And specifically relevant medical ones are smoking and drinking alcohol. Smoking, you have to define it in terms of pack years, and they're relatively simple to calculate based on the number of cigarettes consumed per day and for how many years. A single pack year would be 20 cigarettes a day for 1 year. If I was only smoking 10 cigarettes a day, say for 2 years, it would still be 1 pack a year. Alcohol is very important to document the amount and the type. And you really only have 3 types. You've got Embege, local brew, you've got brewed beer, and then you've got spirits. And whether it's a daily occurrence and the quantity ingested. Nowadays, we like to ask about diet and exercise, because these are the two, what we call modifiable risk factors for non-communicable diseases. Moving on then to one's personal history, you will ask about whether the person is single or married or perhaps has a partner, and how many dependents there are on that particular patient. That's very relevant, and whether or not they are in receipt of any assistance, say from family members, that may be important where there's a disability. Moving on then to the drug history and allergies. If you think about drug history, you have to enumerate each drug the patient is on, and the dose that they're taking on a daily basis, or the frequency of that dosage, whether it's once, twice, 3 times, or 4 times a day, and whether there is compliance. That is, are they actually taking the medication? And that has to be done for each medication. You will ask about any obvious side effects of medications that patients are suffering from or have suffered from in the past. For example, they may be allergic to a drug like penicillin, and that needs to be known. And then more specifically, is there any severe allergy that they are aware of that will inform the doctor about future management? So moving on then with what we call the past histories, you have to go through the obstetrical history and the gynecological history. Obstetrics is very simple. How many times has the patient been pregnant, and how many live children there are, or how many live births there were, and how many live children there are now. That's parity, or gravida and parity, respectively. Obviously with females, it's important to document the year of onset of their menses and whether or not their menses have finished with, say, perhaps with the onset of menopause or disease. And then coupled with that, it's often asked is the frequency of their menses, whether it's every 28 days, and then what we call the amount of blood loss. And that can be quantified in different methods, which you learn about in obstetrics and gynecology. Before we finish, specifically about allergies, ask again if allergic and to what. Name the allergy, specific drug, or what. And in the case of a dangerous allergy, this should be written in large red letters on the front cover of the patient's file notes in order to avoid any mishap. Now, moving past those, we come on to what students are familiar with. Is called the systems review. The systems review is a group of questions relevant to each system which are designed as what's called a catch-all to pick up any diseases that might be occurring in those other systems. These are grouped under about 6 main headings, and you are familiar with them already. I'll summarize them: cardiac, respiratory, gastrointestinal tract, nervous system, locomotor system, and reticular endothelial system. And also not forgetting general. Now, to go back over general in terms of systems review, what kind of questions would you like to ask, or like a doctor or a student to ask you if you were feeling generally sick? Well, the first one would be a specific one about your health. How are you feeling now, generally? That's a good opening question. You can ask about strength, or more particularly weakness. Are you tired, or do you get tired? And specifically, what makes you tired? Appetite is important, because we tend to lose our appetite with disease. And you have to ask about it, because the patient may not volunteer it. And coupled with appetite is always weight loss. Patient, again, may have an idea that they've lost weight rather than a measured weight. And then fever is often not commented on in our environment here because they're so common. You ask, are there any fevers? And in particular, night sweats associated with tuberculosis. And then the patient's general well-being psychologically. How is your mood? Are you sleeping all right? Etc. And then moving on to more specific systems now. And I've listed the 6 main symptoms. I'm not going to go through each of them individually now, because we will go through them in subsequent tutorials individually. But I'll name them again for you: cardiac, respiratory, gastrointestinal, nervous system, reticular endothelial, and locomotor. And the key points that I'd like students to remember about general examination are as follows. Number 1, establish good communication with your patient. You do that by following the protocol we have suggested. Allow the patient to tell the story of their illness. That's very important, without too many interruptions. The specificity of that is so important. And if you are going to ask questions, ask them in a logical order and relevant to the patient's presenting complaint. listen carefully and order your questions appropriately. Observe the patient during the history taking for anything that strikes you as important. For example, the patient may be obviously short of breath, may be obviously pale, may be obviously distressed, or may even have a disability. Avoid over-interpretation early on. Let all the details of the history come in, and later on, the details of the physical examination. And that's the point when we begin to interpret possible causes. And then we like to, what's called, have a construct in our heads when we're identifying what we call the likely anatomical and physiological basis and pathological basis for the patient's symptoms. And this is often called the working diagnosis. Now, moving on to the second main part of what we call the tutorial this morning. It's about physical examination, or what we call physical examination. And physical examination starts with you have to undress your patient appropriately for the examination. You have to make the patient comfortable, whether the patient is actually lying in bed or sitting. You have to be comfortable as the one who's examining. And this will become self-evident as we move through the examination, as the position that's appropriate for the system becomes apparent. And this is the place where you as the medical student, and of course as the doctor, record your first impressions of the patient. And this is actually very important, because this is the point when you look at your patient and decide, is the patient well or unwell? And if the patient is unwell, what is it that strikes you that is abnormal? Now, I'm not talking about small print, I'm talking about big, obvious things. For example, if your patient is unconscious, you say the patient is comatose. If the patient is breathless, you say the patient is short of breath or dyspneic. If the patient is anemic, so grossly that he looks so pale, you say that the patient looks pale. If the patient is in distress, say with severe asthma, you say that the patient is dyspneic at rest, and so on. So the first impression of the doctor, or i.e. medical student, is often one of the most important parts of physical examination. Having said that, then you go on to systematically go through each system. I do emphasize that before you do that, we have these things called the vital signs. Now, the vital signs are usually recorded by the nurse before you get to the patient, but we like to train the medical students to do them themselves. There are only 4. Obviously, there's a pulse rate, there's a respiratory rate, there's a temperature and a blood pressure. And it's good practice for you to do those before you get on with the examination specific. The examination specific then is going to involve each of the systems. Briefly to mention, in the cardiac system, you're going to examine the peripheral bits and the heart proper. The peripheral bits, for the sake of this discussion, would involve the hands, the head, the feet, and then the examination of the cardiac system proper will involve this process of the pulse, the JVP, and then we go on to examine the heart proper in the chest, which involves the following paradigm, or the following system: inspection, palpation, percussion, which we don't do for the cardiac system, and auscultation. Now, I'm not going to say any more about the cardiac examination, but moving on to the respiratory examination is the same. Emphasizing that it will also follow the same process, i.e. inspection, palpation, percussion, and auscultation, but reminding the students that the peripheral bits have to be examined. Again, the hands, and again the head, and again the oral cavity, but this is all part of the entry to the respiratory system, the neck sometimes. And then you go on to the examination of we call it the respiratory, the chest proper. Moving on to the abdominal examination, The abdominal examination, again, I should emphasize that in the cardiac and the respiratory examination, the patient is always positioned at 45 degrees or higher, but not in the lying position, except under very special circumstances. The abdominal examination is going to, again, involve everything from the mouth to the anus, and is going to follow the same procedure. Inspection, palpation, percussion, auscultation. The patient is going to be lying flat, usually with a pillow under the back of their head, just slightly elevating their head from the bed to make them more relaxed. And you, as the examiner, is going to be seated on the stool beside the patient. And again, there are peripheral bits that students tend to forget with the gastrointestinal examination, and they also involve the head and neck, for example, the eyes for the conjunctiva for anemia, the mouth for as the start of the gastrointestinal tract, and the lymph nodes in the supraorbicular fossa, which drain part of the gastrointestinal tract, the inguinal areas, which involve the genitalia, and of course the rectal examination. A point worth mentioning at this stage is that that in addition to the gastrointestinal tract, you have the genitourinary tract. And the genitourinary tract is, by and large, examined at the same time as the gastrointestinal tract, and not emphasized. But on this occasion, you're mainly interested in kidneys, ureters, bladder, and of course, what we call the reproductive organs. For example, females, the uterus, and the genitalia, male and female. Not forgetting that a rectal examination is common to both. And no examination of the gastrointestinal tract is complete without a rectal examination. So now we've completed effectively the cardiac, respiratory, and abdominal, and we move on to the central nervous system. Obviously, the central nervous system is going to involve a bit more complex. And when I do the nervous system, I'll go into that. Effectively, medical students will be examining the cranial nerves, the limbs, upper and lower, and gait. But you're also examining a live, conscious patient. In other words, you're assessing consciousness. And at the same time, you're assessing mental function. And in addition, you're assessing what we call cognitive function, what we are doing now, learning. Mental is our state of mental health. Our mood, and whether our mental health is normal or abnormal. So, in other words, neurological assessment tends to be generically include both mental, cognitive, and consciousness. But most students see it as examination of the cranial nerves, limbs, and gait. And the examination then concentrates on those three areas. Moving on to the reticular endothelial system, we've mentioned that already this week, I think. That just involves looking at the patient's lymph nodes and their liver and spleen, and asking them, do they have problems? In this case, it's examination, not systems review, but you're emphasizing the question of lymphadenopathy and organomegaly. The locomotor system is about examining joints and spine and gait, and usually in that order. The endocrine system is not easily available to us clinically, but if you imagine, we can examine for a thyroid in the neck, you can examine for secondary sex characteristics, i.e. distribution of hair, and secondary sex characteristics. These are all markers for the endocrine system, and they're part of physical examination. So, there are some special senses left, the eyes, the ears, the nose. They tend to be examined by specialists, but every medical student and doctor should be able to assess the basic function of hearing, vision, and smell and taste themselves, rather to test its function. And then the specialized assessment of the organ is usually done by people that are more specialized. Now, in summary then, I always advise students to examine patients, I should say, in a well-lit room, and where the patient is comfortable and you're comfortable. That's ideal. You and I know that life is not like that, but that's the ideal. Make sure the patient is in the correct position, because that's very important for eliciting signs. when you're dealing with the patient, please remember, just like I said at the beginning, the patient is your best friend for that history and depends on you, and doesn't really distinguish between you and the doctor. So you actually have, you know, the patient is, and you are going to make the patient as comfortable as you can. Very important that the patient's modesty is preserved. There are no problems with that here. That's always done. And we do it with a sheet and cover the bits that we're not examining, or not exposing the bits that we don't need to examine. And finally, you know, my teaching is a bit like the magician and his black hat. You know, the magicians, when I was little, used to go around with a nice hat and used to pull a white rabbit out of it and show it to us. And then he would show us the hat with no rabbit. And of course, that still confuses me. I still don't know how he did it. But then he was a magician. What I'm saying is that a physical sign should be demonstrable to somebody else. Remember that as a student. That when you demonstrate an abnormal physical sign, you should see it, and then you should be able to show it to somebody else, and it should be demonstrable, and the patient shouldn't be able to interfere with it. That is the basis of clinical medicine, of abnormalities. I'm just emphasizing that little cameo, our little story, for you to emphasize that part of it. We now come to the summary. Now, the summary is not another case history. It usually involves just one sentence about the patient. For example, I am a 65-year-old man. I presented with sudden loss of consciousness yesterday. On examination, I had left-sided paralysis or hemiparesis, full stop. That's it. That gives the essence of what the problem is. I'm not rewriting the full history. We then move on to what's called this question of a diagnosis. Now, most students will have what's called an idea. We call it the hypothesis. You will have synthesized the history of the examination into what's called a working hypothesis based on your information and your knowledge. And that is what we call the working diagnosis. For example, with the last patient, it's quite likely the patient has had a stroke. And that will be written down. That stroke will be secondary to something, which the student may not be quite aware of yet. And that will be what's called your working diagnosis. Is there a differential? Yes, there might be in our environment. It could be HIV disease presenting with an opportunistic process. That would be a differential diagnosis. Both of those diagnoses will not be firmed up until some investigations are done. So the final diagnosis is often something that comes late. So I'm just emphasizing there is a working diagnosis, there is a differential diagnosis, and there's a final diagnosis. Look, all students like to know after your diagnosis what do you do, and that's called the management or your plan of action. And what I advise students is to do the following. One is list the active problems which require action. For example, with our patient with stroke, it's hemiparesis, requires action, and maybe the cause of it, like hypertension. Both require investigation and management. Then you list the investigations that are suitable for that problem, and concurrently you list the appropriate management as you understand it. Now that is a very simple paradigm. One, list problems, and particularly the active problems. Two, list what we call the investigations for each problem, and then list the management for each problem. And then the rest follows. And that actually concludes the tutorial for today. Thank you.